Thank you, sir. Thank you for including me in the IC. Sir has always been a mentor and guide to us. So I'll be talking in brief about management of sixth and the fourth nerve palsy. So the signs and symptoms of sixth nerve palsy are horizontal diplopia, which is worsening towards the affected side. There's a face turn, and then the measured esotropia is more in the field of action of the paralyzed muscle. So this is a case of acute onset diplopia following trauma. So it's a case of acute traumatic sixth nerve palsy. All that is required in most of these cases is just observation and follow-up because they tend to improve within a period of next 3 to 6 months. This is another case of 34-year-old male presenting with sudden onset double vision. He had mild headache on and off with occasional vomiting. There is no neurological illness otherwise, and there's mild abduction limitation we can see on both sides. So this looks like a bilateral sixth nerve paresis. On examination, the visual acuity is 6/24, anti-segment is absolutely fine, but this is what the fundus looks like. So there's a gross papilledema, and the neuroimaging reveals a large intracranial space occupying lesion. So whenever we have an acquired case of sixth nerve palsy, always do a dilated fundus evaluation and rule out papilledema. Now, management options in the acute phase would be occlusion, prisms, and Botox. But definitive solution comes in the way of surgical once the stability of alignment is there. Surgical interventions for a case of partial sixth nerve palsy, the options would be MR recessions, LR resections, RNR procedures. RNR can be combined with the contralateral MR recessions. So this is a case of post-orbitotomy sixth nerve palsy. We can see a good scar here, and she landed up with sixth nerve palsy. All that is required here is an RNR procedure, and she improves pretty good with good alignment pre and post-op. Now, the sixth nerve palsy has a problem, so we have to think in terms of different options like a partial VRT with MR weakening procedures, which could be a Botox or a recession, a full tendon VRT with MR weakening procedures, or a rectal muscle reunion procedure with MR weakening. So there are various procedures described in the book, like the Hammershim, where there's a partial VRT of the temporal halves. O'Connor made it full tendon VRT with LR cinching. Carlson and Jampolsky advocated adjustable partial VRT. Then we had Jensen's muscle reunion procedures. They were all done to kind of minimize the injury to the blood vessels. Kushner modified to the middle halves, but there were always a problem of strangulation of vessels. So then comes this Rosenbaum talked about full VRT with Botox, and Foster added the Foster's augmentation suture to augment the action of the transposed muscles. Then comes this Nishida's procedure, which is a newer entrant, and this initially it was described with the muscle split, and later the split was avoided. So what we do is we try to shift the muscle about 8 to 10 millimeters from the insertion and 10 to 12 millimeters radially midway between the lateral and the superior rectus, and lateral and the inferior rectus, and there's no splitting of muscles. So we can also add adjustable MR to make it adjustable and modifiable. So it's a case of left post-traumatic sixth nerve palsy. The patient undergoes large MR recession along with the VRT, half tendon VRT with the Foster's suture. And this is the pre and post alignment. So when we do such large surgeries, we do tend to have a little bit of lid anomalies, which are anticipated in these cases. Another case of sixth nerve palsy following a road traffic accident is diplopia in the primary gaze and face turn to the left. So the patient has a right post-traumatic sixth nerve palsy. The patient undergoes MR recession, which is adjustable along with the superior rectus transposition to the lateral rectus. So this is another case of post-viral sixth nerve palsy with diplopia in the primary gaze and face turn. She also goes a similar procedure, MR recession with superior rectus transposition to the lateral rectus. This is 5 weeks post-surgery. And Botox can also be added in the early phase to prevent the MR contracture and make the diplopia amenable or manageable by the patient for some time. Observation can be done in acute cases with no neurological signs, but these days it is important to advise a neurological evaluation even in the subtle changes, whatever we observe. For young adults, look for the risk factors. For adults, if they have vasculopathic factors, they tend to improve on their own with time. Now we move on to the fourth nerve palsy. Now this is one of the most common nerve palsies which is seen. It is usually congenital, post-traumatic, viral, and ischemic. They usually present with a head tilt, asthenopia, vertical strabismus, and a diplopia. And mind that this is never a sign of raised ICT. This is usually a sign of trauma. It may be associated with diabetes and hypertension, which can improve with due course of time. So we have the NAPS classification with respect to the right eye. This guides us which surgery to do in what kind of a particular patient. So the it's commonly seen as a right. This is with the right eye. So if there is a maximum abnormality in lever elevation, so plan for an inferior oblique recession. If there is maximum abnormality in the depression, that oblique tuck can also be done. So accordingly, they have been classified into 7 types, and the surgeries have been advocated according to that. Now, suspect a bilateral sixth nerve palsy with concussion injuries when there is a V pattern or a chin down posture, there is alternating hypertropia, there is an objective torsion of more than 10 degrees, and the patient complains of subjective torsion. So these are all features of a bilateral sixth nerve palsy, a bilateral fourth nerve palsy, which should be looked into. Now, management options for a congenital, again, plan for surgery for acquired cases during the acute phase. You have to wait. Botox may not be a good option here, because if you give it, it's going to create more problems even to the superior, inferior oblique, and inferior rectus also can be involved with the Botox. 6 months later, you can plan for a definitive solution, which can be surgical. Now, Park's 3 steps test helps us identify the culprit of the muscle culprit in case of head turn. So whenever there is a elevation, like in this case, there is a left hypertropia, these 2 muscles are either underacting or these 2 muscles are overacting. So when this hypertropia increases in dextroversion, so we are left with the 2 muscles, that is the superior rectus of the right eye, which is overacting, or the superior oblique, which is underacting. And when we do the head tilt again here, this is in aggravating the hypertropia. So we are left only with the superior oblique of the left eye, which is underacting, and this is how the Park's 3-step test goes. So this is a case of 17-year-old male presenting with head tilt towards the right side since early childhood, and we can see that there is a elevation which increases in the dextroversion, and with the left head tilt, so the elbow L over R increases. So it's a case of left inferior oblique overaction. Left surgery has been done for this patient. So this is the 3-step test, forced surgery, and this is the torsion which is improved. Young boy with a SOP here, we can see there's a marked elevation, but the problem here is in the depression. So the patient undergoes tuck, and this is post-tuck. We have little bit of browns left, but the alignment improves. So in the end, I would just say careful assessment and proper choice of procedure is a key to success in paralytic strabismus, more so in the 4th and 6th nerve. Thank you.